Welcome to the weekly neurology deep dive. Today we're focused on a significant consensus statement from ECTRIMS and EBMT. It's all about autologous haematopoietic stem cell transplantation, AHSCT for MS and NOSD.
It's a really important paper, and we should state up front this is purely for education.
Absolutely. This is a summary, zero commercial goals involved. For the full, detailed information, you absolutely have to go read the original publication.
Couldn't agree more. What we want to do today is extract the key takeaways relevant for clinical practice.
Right. Focusing on the data, the percentages, those crucial recommendations and criteria that help neurologists figure out AHSCT's role for their patients with MS and NOSD.
Okay, so let's start with the basics, the rationale behind AHSCT. The core aim is really to eliminate the immune components driving the disease.
Sort of a clean slate approach.
Exactly. And then that's followed by immune reconstitution, the rebuilding process, hoping to restore immune tolerance and get long-term control over new inflammation.
And how quickly does that immune system rebuild happen?
Well, it varies. You see CD19 plus B cells, CD8 plus T cells, and NK cells bounce back pretty quickly, usually within 6 months.
Okay, 6 months. That's fairly fast.
It is for those types. But the CD4 plus naive T cells and the central memory T cells, they can take much longer, sometimes up to 2 years.
2 years. That delay must have implications.
It certainly does, particularly for long-term immune function and surveillance. Now, beyond just replacing cells, how does it actually suppress the disease?
Good question. What are the mechanisms at play?
It seems to be a combination of things. We see an increase in regulatory T cells, the ones that help calm the immune system down.
So, more regulation.
Yes, and less Th17 response, which is a key inflammatory pathway in MS+, shifts in cytokine patterns towards a less inflammatory state.
Interesting. Anything else?
What's quite striking is a decrease in how reactive the CD4 plus effector memory T cells are to MS autoantigens after the transplant. And also, levels of switched memory B cells, those antibody factories, are reduced too.
Okay, that makes sense mechanistically. Let's turn to the clinical evidence in MS. This consensus reviewed quite a few recent studies.
It did. They looked at 26 publications from 2019 to mid-2024. All had at least 10 AHSCT patients and reported neurological outcomes and, importantly, transplant-related mortality.
And what did these recent studies show for relapsing remitting MS?
Pretty consistently high success rates. We're talking progression-free survival, or PFS, often in the 80 to 100% range.
Wow, 80 to 100% PFS.
And any data, no evidence of disease activity was also achieved in a large proportion, around 70 to 80% of patients in those studies. It really shows the potential here.
Were there certain types of RMS patients who did particularly well?
Yes, the data really points towards younger patients, say under 45. Also those with a shorter disease duration, maybe 5 years or less, and evidence of recent inflammatory activity.
So early and active disease.
Exactly. In that group, they saw near complete PFS and sometimes even improvement in disability levels. It suggests hitting aggressive disease early with AHSCT might give the best results.
The consensus also looked back at older, longer-term data from before 2019. What did that add?
That's crucial for understanding durability. The EBMT-CIB-MTR database analysis, with over 280 patients followed for a median of 6.6 years, was quite revealing.
How so?
Well, 5-year PFS was 73% in the relapsing remitting group, but only 33% in the progressive MS group. A big difference.
That is a stark difference.
Yeah.
What about safety in those earlier cohorts?
The transplant-related mortality at TRM was 2.8% in that specific dataset. More recent long-term data, like from the Italian BMT MS group,
Yes.
with 210 patients, showed a 10-year PFS of 71% for RMS versus 57% for progressive MS, and importantly, a lower TRM of 1.4%.
So improving safety over time as well.
It seems so. And a Swedish series, focusing just on RMS with up to 10 years follow-up, reported an 87% 10-year PFS with 0 TRM.
Zero mortality in that series. That's impressive. Okay, how does AHSCT compare to our current disease-modifying therapies, the DMTs? The paper mentions some comparisons.
Right, these were retrospective, non-randomized studies, so we need to keep that in mind. But 5 studies compared AHSCT to ilimtuzumab. Generally, AHSCT looked better regarding relapses, achieving NAD and MRI activity. The benefit on disability progression was a bit less consistent across those studies.
What about against other high-efficacy DMTs?
There was a propensity score matched study in highly active RMS. It found AHSCT was considerably better than fingolimod and marginally better than natalizumab.
Marginally better than natalizumab. What about ocrelizumab?
Interestingly, it didn't show superiority over ocrelizumab, but the follow-up time for the ocrelizumab group was quite short, only about 1.5 years compared to nearly 4 years for AHSCT, so maybe too soon to tell there.
And in progressive MIS, any comparisons?
One study looked at progressive MS, both primary and secondary, and found no significant difference between AHSCT and natalizumab in that population.
So the picture for progressive MS seems a bit different. What does the evidence overall suggest for AHSCT in progressive forms?
It's definitely less robust than for RMS. Cohort studies without control groups show 5-year PFS in secondary progressive MS ranging anywhere from 33% up to 71%. Quite a wide range.
That is wide. Any hints of benefit?
One registry study suggested AHSCT might slow disability progression in active secondary progressive MS compared to standard immunotherapy, but overall the benefits seem less pronounced, more nuanced than in RMS.
Okay. Were there any randomized controlled trials, RCTs, to give us stronger evidence?
Yes, 2 key ones. First, the ASTIMS trial. It was stopped early, unfortunately.
What did it find before stopping?
It involved 21 patients, about a third with RMS. AHSCT was better than mite-santril on MRI outcomes, but it didn't show a significant difference in disability progression in that smaller group.
And the other RCT?
That was the MIST trial, much larger, 110 RMS patients. This one was quite impactful.
What were the results?
It showed AHSCT was superior to various DMTs, including some high-efficacy ones. 5-year progression-free survival was around 90% with AHSCT versus only 25% with DMTs.
90 versus 25%. That's a huge difference.
It really is. And relapse-free survival was 85% versus 15%. NATR3 achievement was also dramatically better, 78% versus just 3% in a post-hoc analysis.
So, strong RCT evidence supporting AHSCT in highly active RMS.
Yes, the NHS trial provides compelling evidence for that specific group.
Okay, pulling all this together, what are the practical indications for AHSCT and MS that neurologists should be thinking about day to day?
For relapsing remitting MS, the consensus considers it an established option after failure of any one high-efficacy DMT.
Just one.
Yes, if the patient also has markers of aggressive disease, think frequent relapses, poor recovery, new MRI lesions, rapid disability worsening.
And what if the patient is treatment naive that has very aggressive disease?
That's considered an investigative indication. For someone treatment naive with rapidly evolving severe MS and poor prognostic signs, AHSCT could be offered ideally within a clinical trial. If no trials available, then perhaps in a structured observational study.
What about progressive MS then? What is it on the table?
It's much more selective. It might be considered for young individuals, typically under 45, who have early progressive disease, a short overall duration, and documented inflammatory activity, clinical or radiological, within the last year.
So active progressive disease.
Active and progressive. They should also be worsening rapidly despite being on DMTs. Crucially, it's generally not recommended if there's no detectable inflammation or if the patient has long-standing advanced disease with severe disability already.
Are there general criteria for who makes a good candidate overall and who shouldn't get it?
Yes, the general profile leans towards age under 45, disease duration under 10 years, rapidly evolving, severe inflammatory active MS that's often treatment refractory. EDSS usually below 6.0 unless a recent relapse caused a temporary increase. And of course, capacity for informed consent is vital.
And contraindications, what rules it out?
Major ones include active cancer or myelodysplasia, any uncontrolled serious infection, or uncontrolled psychiatric issues that might interfere with adherence to the whole process, which is quite demanding.
Okay, let's shift gears to NMOSD. How does AHSCT fit in there, especially now that we have effective targeted drugs?
You're right, the role has definitely shrunk because those targeted therapies are often highly effective in NMOSD. The EBMT registry data on 16 NMOSD patients wasn't overly encouraging.
What did it show?
Only 48% PFS at 3 to 5 years, and a very high relapse rate, 81%, with relapse happening pretty quickly, median 7 months.
That doesn't sound great. Any conflicting data?
There was a prospective study, 13 patients, using a more complex protocol involving cyclophosphamide plus rituximab that looked much better.
How much better?
They reported 90% PFS at 5 years, improvement in EDSS, and 80% were free from both relapse and ongoing immunosuppression.
Okay, so maybe the protocol matters a lot in NMOSD. When might we still consider AHSCT?
It could be a rescue option for patients truly refractory to multiple standard treatments, or maybe as an induction therapy for very aggressive initial presentations, especially if using regimens with anti-CD20 or other antibody-depleting agents.
An allogeneic transplant.
That's really reserved for rare cases where AHSCT fails and there are literally no other options left, very much a last resort.
For neurologists whose patients might be heading towards AHSCT, what should they know about the actual transplant methodology recommended in the consensus?
For MS, the recommendation is for intermediate intensity conditioning regimens. Think beam ATG or cyclophosphamide ATG.
What about other intensities?
Low-intensity regimens aren't generally recommended outside of trials due to efficacy concerns, and high-intensity ones carry more toxicity risk, so they're usually reserved for specialized centers or trials too.
And for NOSED, if it's used.
If indicated, cyclophosphamide-based protocols, perhaps including rituximab as seen in that more successful study, seem appropriate based on current evidence.
After the transplant, what's crucial for neurological follow-up?
Post-AHSCT care needs structure. Rehabilitation is key, often outlined in 4 phases. Clinical monitoring should include EDSS, MSFC, and considering things like cognition, fatigue, quality of life.
How do we track disease activity?
You need to monitor for both relapse-associated worsening and that insidious progression independent of relapses, PIR. MRI monitoring should follow Magnum's guidelines with a new baseline scan around 6 months post-transplant.
What if the MS reactivates?
That needs to be managed individually. If there's a confirmed relapse, reintroducing a DMT might have to be considered.
Finally, let's talk complications and prevention. What key things should neurologists be mindful of managing post-AHSCT patients?
Prophylaxis is huge. Revaccination post-transplant is critical. Follow national or international guidelines. Think pneumococcus, flu, VZV, SARS-CoV-2.
What about infections hiding in the body?
Viral reactivations are a major concern. Monitor closely for CMV and EBV using PCR assays, especially in that early period, days 15 to 60.
And if they reactivate?
Preemptive treatment is standard for CMV reactivation. For EBV reactivation, active surveillance for EBV-associated PTLD is crucial, and preemptive rituximab might be considered for high-risk patients.
Any other potential long-term issues?
Secondary autoimmunity can occur. Thyroiditis is the most common. Maybe be extra vigilant if the patient had alemtuzumab before AHSCT. There's also risk of late adverse events like infections, especially in the first 2 years, and a potential, though still not fully defined, risk of late malignancies. Standard infection prophylaxis is definitely needed for the first few months.
This has been a really thorough deep dive into the AHSCT consensus for MS and NMOSD. Lots of practical points there. But again, this is a summary.
Absolutely essential to consult the full source document for all the nuances and complete details.
Right. The landscape keeps changing, and understanding when AHSCT fits, especially with ongoing trials comparing it to the newest DMTs, is vital. Hopefully this gives our listeners food for thought on managing those challenging cases of highly active MS or refractory NMOSD.
It's a complex decision, balancing potential benefits against significant risks. Staying informed as more data emerges, particularly from those head-to-head RCTs, will be key.
Definitely. We encourage everyone to explore the full publication. Thank you for joining us for this weekly Neurology Deep Dive.